Okay, let's go ahead and get started. So management, your foundation is always going to be lifestyle, always. Drugs will never be your foundation. There will always be an adjunct to the management of obesity. So the goal is to prevent or treat or reverse the complications of obesity. So those are what?
Cardiovascular.
Heart disease, diabetes, hyperlipidemia. What about joints? Knees, hips, back,
Fatty liver.
general, brain. Okay. So 5% goes a long way. Baby steps go a long way. So 5% of a 200-pound person would be what?
10 pounds.
10 pounds. Have you ever lost 2 or 3 pounds and felt like it was great? So this gives people hope. So you can set small goals. Now, I used to do that with patients. I'm going to see you in 3 months. I want you to have lost this amount of weight. After discussing with them and trying to figure out what would be reasonable, setting a goal. Safe and reasonable weight goal loss is considered to be 1 to 2 pounds a week. Okay, so that's about a 500 to 1,000 calorie deficit every day. It's best if it will be a mix of calorie restriction and exercise. In weight loss, calorie restriction is the biggest deal. Exercising alone usually will not get it, for most people, okay? Exercise usually comes in more in maintaining a weight loss than it does in being the sole intervention to decrease weight. So talking to patients about increasing their energy output, decreasing their energy intake, and how that would look is important. Let's see. Lifestyles usually will get you 5 to 7 pounds, 5 to 7%. That's pretty good. Drugs do not add a whole lot. Drugs usually are in about the 5 to 10 kilo range. They're not huge. They may help, but if the lifestyle isn't there, you can out-eat them. Initial treatment is diet, exercise, behavioral modification. That behavioral modification is probably most important. Getting them in with a dietitian who can work with them if they have a disease that is something they can bill for, or getting them into a program like Weight Watchers that will teach them those things through the program is important. Nutrisystem does that to some extent, but not to the extent Weight Watchers does. Jenny Craig does a fairly decent job of that approach as well. So any of those that modify the portion control and tell people when to eat is usually helpful. But I don't think anybody beats Weight Watchers in terms of just their teaching of people how to deal with the behaviors that lead to good health and sustained weight loss. That's my opinion. Dietary adherence is the #1 predictor of weight loss. Exercise we talked about. Here you're wanting to promote them to at least meet the minimum guidelines, the 30 minutes a day or the 150 minutes a week. I will tell you with weight loss, people usually do better if they are going for about 45 minutes to 60 minutes. It takes about 20 or 25 minutes, I think, to work through the glycogen that you have, so then to start tapping adipose stores is usually after that point. Are there any exercise physiology people in here? Is that, am I right? Do you remember that?
What was it again?
It takes about 20 to 25 minutes to get to use up like your glycogen stores, and then you start relying much more on adipose stores after that point.
Sounds about right.
I think it's in the ballpark. Okay. But again, wherever people are, and have them advance. If they're already walking or having an exercise, and maybe increasing intensity. If they're just starting one, then working with them on something that's reasonable and setting goals. Always looking for the potential for heart disease underlying their inactivity or sedentary lifestyle. It's those long-term changes in eating behaviors that will last. That's why I like something like Weight Watchers that is instructive. learning to modify cues, stimuli. What do you do when you go to a party where everybody's eating in a way that is, adverse to what you're trying to do? Going someplace and you don't have the you don't have the type of foods you need. What do you do? If everybody's drinking, what do you carry around? So those kinds of things are taught in well-organized behavioral programs. Subsequent treatments, so if unable to achieve a weight loss, so the indication for medication is the same. You'll see it, I've repeated it with every drug that the FDA has put, is if they are greater 30 or greater BMI, so they'd be obese, or they are overweight with comorbidities that would respond to weight loss. Then a drug therapy, in addition to lifestyle intervention, it would be an indication. For those who have a BMI of 40 or over, or have a BMI of 35 with comorbidities, we'll list those out when we get to the bariatric surgery section. Or if they even have a BMI of 30 with uncontrollable type 2 diabetes or metabolic syndrome, they are a candidate for bariatric surgery. Okay. So now let's talk about the drugs. What I'm going to tell you is my opinion. My opinion over time, watching drugs come on and off the market, is that the body really does not like us to mess with our energy consumption or our energy storage. I have watched so many drugs go away, go off the market because of that. That's what I think is going on, is that it is so basic to our survival that you really start to, when you start to undo the ability of the body to contain energy, it pops up bad in many places. You're probably too young for the fen-phen.
My mom took fen-phen, I remember. She had to come off of it. It made her like so forgetful and weird and spacey.
Did she have any heart problems secondary to
I
it?
don't think so.
Okay. Yes.
I actually had a friend in high school whose mom passed away from fen-phen.
Yes, I worked with a dietitian who died due to the pulmonary hypertension.
I don't remember what that drug it was. It might have been that, but my mom ended up developing a heart murmur.
It could be,
So
could be.
it was probably, was it around like 20 years?
96?
Yeah, so it was right, it was like right before my sister.
So in 96, a drug came out. They were both on the market. They put them together. So either one by themselves were effective weight-reducing drugs or anorexics. But they put them together and they called them fen-phen. They were phentermine, which is still on the market, and Dexflu, is it phenazine? Fenfluramine, sorry. There was dexfenfluramine and fenfluramine. So they called them fen-phen. Extremely effective drug. And it was just dispensed like water. I remember, so about that time I was in a neighborhood where there must have been 60 kids, all Cameron's age. And I would go to these parties. We'd have our little dice parties and our card parties. And all these skinny women were talking about being on fen-phen because they wanted to lose 10 more pounds. It was incredible. So if you read the backstory of it, though, it's really disturbing because there was already data on fenfluramine that it caused heart problems. And the FDA wanted to put a black box warning when they approved that combination. The leader of that team that took the recommendations to the FDA would not sign off, the FDA did not want to put the black box warning. Because they refused that, the head of that group refused to sign off on it. So they went around him and got somebody else to sign off. So once it went on the market, then there started to be more and more reports of valvular dysfunction. So mitral valve prolapse became much more, or mitral valve disease became more and more prevalent. And then it got to the point where they put a warning on there. But what really caught people's attention is when young women started developing pulmonary hypertension and dying from it. That got it, and that killed the drug eventually. So there was a huge lawsuit. I mean, it was billions of dollars. And they recommended for, I don't remember what the time period was, it was many years, that women had an echo that had been on it. And so they were following those valves. But we did have a dietitian. She was about my age. She had a child about 8. She either remarried or she and her husband had twins. After she had the twins, she wanted to take weight off. She went on fen-phen, developed pulmonary hypertension, and died about the time those twins were probably a year or 2 old. So very distressing, very bad. So that's why I'm saying have a healthy respect for medications. They really aren't the answer. But they are there and they're available, and so we'll go through them and we'll talk about what their mechanism is and what their expected weight loss is. Most of them, the FDA has now written into almost in all of these drugs, if at the 12-week mark or the 16-week mark for one of them, if a weight loss of thus has not been accomplished, take them off the drug. And usually it's in the 4 to 5% range, so you're usually talking in probably the 8 to 10 pounds. If they haven't lost it, they're not going to. So we'll see that as we go through. So the first one is Orlistat. It is probably one of the safer ones from a cardiovascular standpoint, has some nasty GI side effects. But it came on the market, I don't know, 10 or 15 years ago as Xenical and as the prescription. It is over the counter as Allied. It is half the dose of the RX, so you can buy this over the counter. Considered first line because of the cardiovascular profile is good. All the rest of them that we're going to see have cardiovascular problems. Mostly increasing heart rate and worsening of hypertension is the main problem with the rest of the drugs. These drugs alter fat digestion. They inhibit pancreatic lipase. So you can't break down fat, so you excrete it in the feces. So it's pretty good. It will lower, weight loss in the 5 to 10 kilogram range is pretty good. It's even a drug that you can use for sustained or maintenance weight. The rest of these it's very hard to do because of their side effects, but this one could be used in low dose. Pretty effective. It keeps you from absorbing the fat that you eat in a diet. Okay. So, I put down there even weight maintained up to 24 to 36 months with continued treatment. That should be understood. It's been shown to reduce diabetes incidence, lowering or improving blood sugar control, improving blood pressure, lowering LDL. Duh, you can't absorb the fat, can't get it in there. Side effects. Okay, so here's the worst part. So they recommend that you not eat more than 15 grams of fat at a meal. They recommend not exceeding 30 grams of fat in a day. They put that 15 grams in there so that you don't eat all 30 grams at one meal. Because if you do, that's when the GI side effects occur. So that fat just turns to liquid in the gut. And so fecal incontinence is very common. So they will have bowel movements with no control, or they will excrete this oily substance, fat, without any control. So they can stain clothes, and it's embarrassing, and lots of gas production. But if you stay under that fat content, usually these are minimal, and they are not as... So you don't want to go on an Atkins diet and take this, because your side effects will be pretty bad. They can decrease the absorption of fat-soluble vitamins, so it's recommended that these people take a multivitamin. It has A, D, E, and K in them. Some severe liver injury has occurred. That's fairly minor, not minor in terms of its severity, but a small percentage. Has been also reported to increase the risk of calcium oxalate kidney stones. So a fairly effective drug. drug, patient can buy it over the counter at 60 milligrams. It's usually taken twice daily, I think. You could up that dose to 120 with the over-the-counter. It's expensive though. It's expensive enough, and it's enough of a theft item that if you go to Walmart, you have to pick up a card and go to the pharmacy and get it. So it comes this way. The initial kit, it looks like this. So they've got the capsules that you can take or put in there and carry with you. And then they do have a nice handout inside that talks to you about weight control and dietary choices as a supplement. Questions about those? Oh, it's 3 times a day. So it's 60 milligrams 3 times a day over the counter and 120. But still very expensive over the counter. Not a bad one to consider. The next one is Velvic, or Lorcaris, I can never say it, forget it, Velvic. This one is a controlled substance. It is a serotonergic product. It is, so fenfluramine was a serotonergic. It was a 2C. This one is a 2B, I believe. Sorry, fen was 2B. This one is a 2C receptor. So it works on the satiety centers in the brain to decrease or to improve satiety after eating. So pretty effective in about the 4 to 5 kilogram range. You see an improvement in blood pressure, lipids, diabetes, all associated with it. The side effects, think of the SSRIs. So think about the side effects we had with those. So there are serotonin receptors in the gut, so often there will be some type of nausea, dizziness, diarrhea can occur, headache. Fairly well tolerated. In patients who, anytime you put a patient who has diabetes, it's on glucose-lowering agents, and you put them on a drug that will decrease their appetite, always have them monitoring and adjusting drugs down so that they don't get hypoglycemic. You may have to do that if they lose enough weight with their blood pressure medicines as well. Dosing, it is twice daily. It's no titration involved. Neither is it with the orlistat that we just talked about. Here is the thing. If they do not, by 12 weeks, lose at least 5% of their body weight, so that would be about 10 pounds for a 200-pound person, they recommend taking it off. Don't use it during pregnancy. Don't use it with other serotonergic drugs. So don't use it with SSRIs or SNRIs or MAO inhibitors, tricyclic antidepressants, because of the risk of serotonin syndrome. You'll see under adverse effects that third bullet is no significant increase in the incidence of serotonin-associated valvulopathy. That goes back to that fenfluramine. But they work on different serotonin receptors. Questions about those? Any stories about that one? Hasn't been on the market very long. I think 2012 is when it came out. Yep, 2012. Okay, so the sympathomimetic drugs. So these have been around forever. So amphetamines were used for a long time for weight loss. Women love them because you could lose weight and stay up all night cleaning your house and go to work the next day. So the ones that are on the market, phentermine is probably the most common one in the past that's been used. It's very effective. It's a controlled C4. You'll see the other one, diethylpropion tenuate, another really common one used in the past, another C4. The other two, Diedrex and Bondril, are C3s. These are recommended for short term. I can guarantee you they're used long term. There are side effects, so think cardiovascular, think insomnia. So often these women, or I say women, people that take them usually have insomnia early on. So getting them to take the drug first thing in the morning is important. If they take it later in the day, their sleep will really be disturbed. Eventually they may adjust, but for the insomnia, take it earlier in the day. Contraindicated in people with heart disease, hypertension, hyperthyroidism, or people with a history of drug abuse, since they are amphetamine-like. One thing I put up here, because it may be a concern for your patients, is will it show up on a drug test? Yes, it will. It has an amphetamine-like structure, but it's a legal substance, so whatever they have to do to alert people if they're being regularly drug tested at work, they need to know about it. Average weight loss, 7.4 kilos, pretty good, almost 15 pounds, a little bit more. Sympathetic side effects, increase in heart rate, blood pressure. So if you remember the contraindications, you remember the side effects. Insomnia, dry mouth, constipation, nervousness. Questions about those? Yes?
So, I know people who are taking Phentermine are probably working out too, and I know a big thing with working out is taking pre-workout, which
Yeah,
increases
be
your heart
careful.
rate. Like, should we tell them not, like, to avoid things like that are over the counter? So they don't stroke out while they're working out?
Taking what over the
Like
counter?
a pre-workout that's going to increase their heart rate and,
What is a pre-workout? Maybe I don't know what you mean.
I don't know what's
It's
in it.
ingredient.
You know?
A lot of it is creatine, but
Like,
It vasodilates and it like increases your heart rate
and why would you take
because
it?
it burns fat while you're working out.
and it increases.
And you believe that?
I mean, I blew up. If you ever drink a pre-workout, you'll be up for hours.
I'm against it.
I wouldn't do that. I'd say don't.
I just
Don't
don't-
tell them not to do
It was
that.
very popular on the workout market.
Really?
So, I had friends in undergrad who would drink pre-workout at night to stay up all night for their test, like the studies. It gets used not great.
Okay, don't do that. Intolerant. So what is, there's gotta be a
different
caffeine related
kinds.
product.
There's
isn't there? Caffeine, creatine.
It depends on the pre-workout, they're all a little bit different, and like what their concentrations.
Nice.
Nice.
Okay,
I have a lot of patients that were on chronic opioids and amphetamine. Do you not think that that's a terrible idea?
and why were they?
Because they were chronic pain patients, so they were there for pain management, and then
Should
they
not
were
have been
taking
put
that
on
for
that.
weight loss.
Yeah, probably should not have been put on that.
I totally agree with you.
Any other comments? Okay, liraglutide, where have you heard of this one? Victoza is its other name, first name. So where's Victoza? How do we use it? For diabetes. So it's one of the GLP-1 receptor agonists. So it is a drug that increases GLP-1. So one of the reasons we use it in diabetes is it increases satiety. People quit eating or they get fuller faster, the feeling of fuller faster. So to be one of the reasons it helps in diabetes, but the other thing it does is it increases insulin levels related to the blood sugar at the time. So because when people were put on these drugs, they noticed that they lost weight. They went after, at least liraglutide went after a indication with the FDA. So they are FDA approved for weight loss. You see that they use a different name though, Saxenda. So this is very common with companies, is that if they go on the market for one thing and they find a benefit that has a great market for something else, then they come back and they give it a different name. Okay, I get it. So patent-wise, they'll have a different patent line for that, different patent line for the diabetes. But the problem is that you don't want to put them on both. So that's the biggest thing, is knowing that there are other drugs on the market with the same name. Okay. So again, these are adjuncts. In terms of the dose is different. It's higher for weight loss than it is for diabetes. So with Victoza, we start with 0.6 and we work them up to 1.8 or 2.4. Here, the dose for weight loss is 3 milligrams. I've had people that can't tolerate 0.6, so I've never seen anybody on that high of a dose that can tolerate it. But if they can get there, it would be probably helpful. So this drug, you can titrate. You can use those lower doses to titrate them up to 3 milligrams a day. So it's an injectable, so they would have to inject themselves. The side effects are mostly GI, nausea, vomiting. The worst things are pancreatitis is a possibility. Let's see what else. Oh, remember about the medullary thyroid cancer increase? So if they have a family history or if they have a history of medullary thyroid cancer because of animal studies, the recommendation is don't use it. Or MEA2, so multiple endocrine abnormalities in the family or they have it themselves. It's recommended, it's contraindicated. Let's see, I think they have a 12-week marker too. Oh, this is the 16-week one. So after 6 weeks, if they have not lost at least 4% of their body weight, then they recommend taking them off. I have seen people on this class of drugs continue to lose over time. I mean, just continue to lose. There is a group up in Gonzaga, what's that, Washington State? Practitioners up there who, they were some of the first groups to use them and they were part of the drug studies that got the drug approved. They talk about super losers, people that lost up to even 50 pounds while on the drug, and that was in treatment for diabetes. So who might be good to put on this? Who might you recommend right off the bat to try these? Diabetics, who else?
People who can't be as physically active as way?
Possibly. I'd really look at pre-diabetics. Or people at very high risk that still don't show glucose abnormalities but have many risk factors. Those might be good ones to consider. Or cardiovascular. It's been shown to not have cardiovascular side effects, so that might be another one to look at. Okay, so those are the 3 single agents. There's 2 combinations that are on the market. That's Saxenda. So it looks just like the Victoza.
Do you know how much that is, the Saxenda?
No, I don't, but I know that Victoza was, it was in the 3 to 6, it was like, let's see, Byetta when it first came out was $600 a month. So I would imagine it's expensive.
Yeah, we have a family friend that just got diagnosed with prediabetes and they got put on that, but she said that the medication is like outrageous.
Yeah, I would imagine. I think they have, I don't know if they've been approved for prediabetes, but there have been studies looking at their reduction in progression. So I think there's data out there about it, like you have with metformin and some of the other
Yeah, because I know they started her on like a bunch of other weight loss stuff to try and reduce, but it was like kind of refractory, so then they are trying this to see if that would help.
Okay. Well, I know that was the original, was 600. Dylan, you know at all, like Byetta cost or Victoza cost?
I think I remember the last time I was there, it was around 25-ish, and there was a few coupons out there for it, but
That's the full cash price?
Yeah.
Well, there was, when I worked in the pharmacy, they always had coupons. I think, and there
there
was
was
one
I
that
didn't see any
always,
coupons for it.
I mean, it's like $25 a month or something with the coupon, because they were brand names, so they were from the manufacturer.
Yeah, the biggest thing with those is its sustainability. They'll do a lot to get you started, but it's the sustainability, like after a few months, whether they're still there. So, not a bad one, if you can tolerate it from a GI standpoint. That's the worst thing about these drugs. And I told you I had about 50-50 of Victoza. 50% could tolerate, 50% could not. But the people who could tolerate it did really well, really well. They lost weight, their blood sugars came down amazingly. Any other comments or questions? Yeah.
I just had a question. I can't remember from Endo, but does metformin help you lose weight for pre-diabetics? Or
You
no?
know, it's considered to be weight neutral. A lot of patients will report that it does. It's one of the drugs that is a non-approved that they put out there to look at. I'd say if you've got somebody who is pre-diabetic, if they are high cardiovascular risk, that it's not a bad one to try, but it really doesn't have an approval, and it's variable. It's not a predictable weight loss. Amy, I saw you shaking your head. Do you have any other experience with metformin that? With
Oh, no,
weight
I
loss?
just thought that I remembered that it did help people lose weight.
I usually tell people, no, it won't, but some people do. Some people,
In a pre-diabetic who is controlled with metformin, would you have to watch what this drug would do to their blood sugars and adjust your metformin dose? Probably not.
no, because metformin, the drugs that you have to worry about for low blood sugar are the ones that affect insulin. So most of the, if you don't have them on like a sulfonylurea or insulin, then adding this is to metformin, probably not. Very low risk. What else? Yes, Ron.
I remember you saying, or I remember learning that metformin is weight neutral, but so since there's variability, and could it be because of the GI upset side effect that people actually lose weight?
You know, I have not, no, and I'll tell you the group that tells me the most that they lose weight are African Americans. I never saw it in Caucasians. I never had them tell me that help lose weight. But it's minimal. I mean, you're talking about maybe 4 or 5 pounds, which is sizable. I think some of it may be if people's appetites come more into norm, they just don't eat as much, that's my opinion. Okay, phentermine topiramate. So topiramate is Topamax. Where do we use Topamax? Say it again? Seizures and migraines. Okay. Remember Sony, remember her story, because she, what was it, 16 pounds? It's quite a bit of weight when she was on it. So they put these two drugs together. Topamax by itself does not have a FDA-approved weight, but they put it with phentermine, and its weight loss is pretty impressive, 8 to 10 kilograms over a year. That's 20 pounds. That's pretty high for a drug in terms of weight loss. It's an extended release, same indication in terms of BMI that you see with the others. Contraindications are cardiovascular disease, which goes for a lot of them, and pregnancy. Common adverse effects are dry mouth, constipation, paresthesias, that comes from the Topamax. Depression comes from the Topamax. Cognitive decline comes from the Topamax. It's also contraindicated because the increased risk of orofacial clefts. So in this one, this one can only be dispensed by pharmacies that are signed up and that are they require certification to dispense. Physicians who dispense usually have to go through a training. So anytime you see a drug that has widespread application in females that are in reproductive age, usually you're going to see the same kind of thing. We saw it with the Accutane. Similar is that you can only go to special pharmacies or special monitoring, and the physicians have to have some type of approved training. Also produces renal stones. So very effective drug. It is not considered first line. This would be in people who you're running out of options. The dose is titrated. You'll see multiple doses there for the combination. And they work on increasing it like every 1 to 2 weeks. If you get to 12 weeks and their 3% weight loss isn't there, which isn't much, then they recommend discontinuing it. Oh, wait a minute. So the 3% is, okay, the 3% is increasing the dose to the final dosing combination, and then it's the 5% in 12 weeks. The caveat here with this one is that you can't abruptly stop Topamax because of seizure increase, so it has to be titrated off. So keep that one in mind. The last one is Contrave, really unusual drug combination. So it's bupropion. What is that drug? It's an antidepressant. What else do we use it for?
Blood pressure?
Smoking cessation. Here's another one of them. Wellbutrin is the antidepressant, Zyprexa is the smoking cessation. So this one they've added naltrexone. What is that? Its cousin is naloxone. So what do we use that for? To reduce opioid overdose? Same here, same, it's an opioid receptor antagonist. So this one, same indication for drug, decreases weight by about 4 to 5%, so it's in the range of most in the low end. Can increase blood pressure, heart rate, increases risk of suicide ideation, that goes with the bupropion. Contraindicated in uncontrolled hypertension, seizure disorders, if you think back to bupropion, it lowers seizure threshold. Eating disorders, chronic opioid use, and haven't used an MOAI inhibitor in the last 14 days. Okay. So what's interesting is the naltrexone is in there because of the way bupropion works, and this little diagram takes you through it. In the center of the brain that it works, eventually you lose the anorexic effect because there is an autoinhibitory pathway that comes back and re-stimulates that part of the brain to eat again. So the naltrexone disrupts that. So that's why it is there. And that's what makes the combination more effective. So those are your 5 FDA-approved products. Questions about those? Okay. So Lifestyles Foundation, then look at your contraindications, look at the set up a reasonable expectation for people. Some of these drugs can be used long-term, some cannot. Look at your underlying other disorders or obesity-related complications that already exist. That may help you and guide you to what to choose. And then cost may be a player in there as well. There are a ton of over-the-counters and a ton of herbal products and supplements that people use. You see them advertised on TV. I can tell you across the board they are not effective. So don't recommend them. I would even, for some of these, tell patients, don't take them. It's a waste of money. Some of it is placebo effect early on, yes.
Have you ever heard of, my dad used to use this stuff called Sensa. It was like a white powder for weight loss, and you like put it on your tongue and it like,
It's for satiety, right?
yeah, something like that. He said,
I don't know what's in it.
I have no
the
idea,
ingredient.
but I guess they pulled it off the market. I just didn't know if you knew anything about it, because he said it worked really well. It like cut his appetite down a lot.
Wonder if it had ephedra in it, because that's what they've taken off the market. So Mulwang, ephedra, a lot of the Chinese herbal products have that in it. So they took ephedra off the market about a decade ago or more because of increased cardiovascular deaths and events with that drug. So you can still get these through in other countries. Really discourage your patients from using those. That Hoodia is another one that is very popular. It also has lots of cardiovascular side effects. Bitter orange is another common one that people like to use. Again, it is a source of synephrine. It's a sympathomimetic. So if people take it and they're using other things as well, it increases the risk.
I found Sensa on
Okay.
Sensa sprinkles are food flakes made from maltodextrin, tricalcium phosphate, silica, and flavors. Sounds like nothing.
It's snake oil. A lot of it is brain, it's how people perceive it, it's placebo effect.
It did say that people were using it to replace like salt and sugar on their meals, so if you're using that instead of salt or sugar, I can see that.
Did they say why they took it off the market?
I just thought that it was definitely ineffective, or that their claims were negative, but I'll see them.
Supplements, are they required to show efficacy? Are they required to show safety? Yes, to an extent they are, and if adverse effects start to pile up, the FDA can take them off the market. They do not undergo the same standards that drugs do, or prescription drugs. Other things, green tea, chromium, gargum, chromium picolate, what's another one? St. John worts. They all have some health claims, but they don't have anything. You'll see it on the label. It says is not used to promote or treat disease. Okay. I'm telling you, they're worthless. Tell patients to stay away from them. They may listen to you. So that's obesity. Questions?
I had a question. It just said it was taken off the market because they didn't have any scientific evidence.
Yeah, it just looks like
They were
got into
sued
a lawsuit
for false
over
advertising.
false marketing, so they actually do still sell the product, but they've had to back off their marketing.
They don't promote.
And they don't have any new like research or claims to make.
Okay, now that's the one thing the FDA can go after supplements is if they start to promote or say that they do something. They can do that. Okay, very good. All right, let's look at bariatric. This will follow in pretty easily. Oh, well. So what do you know about bariatric surgery? What do you think? What?
Lots of people in Mexico.
Are you kidding?
I know someone that
You
does.
don't know this, you live in a different world than I do. What?
My stepsister-in-law actually just went like a month ago to Mexico. They go to California and then they fly you down there. You stay for 2 or 3 days, have the surgery, and then they fly you home.
Does it not scare you?
Yeah, I thought she was crazy for doing it, but
Whoa.
it's expensive here. It's cheaper there. She could pay cash price and get it done for like $2,000 versus here.
Oh yeah, it's way cheap,
It's
way
super
cheap.
cheap.
Wow, well, okay, so which kind do they do?
I'm not sure what kind. I didn't ask details. I didn't want to know.
Okay, all right, that scares me. So what else do you know?
There's lots of complications with them. I mean, even when done well, people tend to still have lots of issues.
And it's still a lifestyle change afterwards.
It's a huge lifestyle change.
There's a lot of criteria to be able to get it.
There are a lot of criteria, we're going to talk about that pre-surgery. So a good clinic, the one I've worked with mostly is the one in Norman. I think they're excellent in terms of what they put people through and what they have to do before undergoing the surgery.
I have a couple of my friends have had that surgery, and I know that they, like, it's definitely not something that is like the first line thing to do, but it like runs in their family, and it's something that I've seen them like try to combat over the course of their lives, because I've known them since grade school.
Yeah.
And so they finally like went ahead and did it, and they did eat healthy, but it was just kind of hard to like, they would lose some weight, but they really couldn't get into a healthy weight range, and so then they both went ahead and did this surgery, and they've, like, it's not a miracle cure, and they're still eating healthier and exercising, so it's been cool to see how like that's actually been helpful for them.
Okay. Depends on what kind they had. Do you know what type?
I don't know.
Okay.
I know it was really helpful for my dad, because he was super healthy until he was in his 40s, and then he started gaining a lot of weight, and he could lose the weight, but he couldn't keep it off for anything, and so now he's like way healthier than he's been in a long time, and he looks really good. Like, but you have to, he's one of the few that's like very diligent, like he gets up early every day, goes to the gym, he has to make sure he gets like 80, I think it's like 80 grams of protein every day. And then he has to take a lot of supplements, and so he has to be very diligent. So it's almost harder than actually just losing the weight on your own if you can keep it off without the surgery.
Okay. Anyone else? It is not for faint of heart, and I think that's why that pre-surgery time that they have to go through is so important for the assessment. We'll talk about what that entails, but also so they will understand what they are taking on, because it is extremely difficult. And it's a big change. And you are trading off one thing for another. So I'd say I had a handful, 6 maybe patients that I saw go through it in our diabetes clinic. So working with them before and after was eye-opening. Okay, so prevalence, it is a very fast and rapid growing surgery. In the United States and Canada, there's about 100,000 a year that are done, that I could find data for. In terms of candidates for a bariatric surgical procedure would be a BMI of 40 or greater, without any comorbid illness, or a BMI between 35 and 39 or right under 40 with at least one serious, and there's a long list and you see those. So uncontrolled diabetes would be one, sleep apnea, hypertension, hyperlipidemia. Usually these folks will have multiple ones. Fatty liver disease, Pickwickian, bad reflux, asthma, venous stasis disease, severe urinary incontinence, debilitating arthritis, impaired quality of life. So a lot of comorbidities, most of them will have multiple in that range as well. The last one is 30 to 35, and so those are folks with diabetes and or metabolic syndrome. This surgery comes about as close to a cure as you can get for type 2. Most of the time, if they're well controlled and they do well after the surgery, usually they come off medicine. A lot of that is not due necessarily to the weight loss, but to the hormonal changes that occur after the surgery. So contraindications, who should they not take place, would be not performing of it for things that could be cured through other ways or treated through other means. For the very young and the very old, it's more controversial. I know that the adolescent rate of bariatric surgery has gone up. Still a controversy in who exactly to do that in. I don't think it's been well worked out, especially for those over 65 in terms of lifestyle or in longevity. I don't even know if Medicare will pay for it. I'm not sure. Other medical conditions that would preclude surgery would be untreated major depression or psychosis, eating disorders. So I told you bulimics can be obese. So finding that out is part of the pre-workup. Alcohol, drug abuse, cardiac disease that would prohibit them from having surgery, severe coagulopathies or inability to comply with what's required after surgery. Okay. So if you, as a PA, you would be referring patients into centers that do this, and they would do the workup unless you're working with them. Most of them have multidisciplinary teams. Has anybody done any shadowing in those areas or worked in those areas? So Taylor, what'd you see?
Well, mostly that I was actually surprised with was like tough love. I felt like even though a lot of people like came to them, they were kind of still in denial that they were overweight, and the doctor was really adamant about, no, you're 400 pounds, your BMI is this is what you should be, this is what you're gonna have to do. Just like, I was just really surprised at how direct it took me back a little bit, but I mean, I didn't know all the criteria either, that was one thing. And all like the team of people, nutritionists, dietitians, things like that, so.
So usually they're assigned to a dietitian who will assess and then will, the ones I've worked with for the most part require them to lose weight prior to the surgery. They'll also require them to go on the diet that they're going to have to be on once they have the surgery, so they can start to understand. So most of them wanted them to lose weight as a sign of that they could comply with the diet, but also just to show they could lose weight. And then they also worked with mental health specialists to evaluate them from a psychological. That's a huge part of the pre-workup.
I want to say too, I remembered something about the guidelines, like if they lost more you know, like they give them a percentage of weight to lose. And I remember thinking it was kind of like an ethical issue, because if they would get close to that line where they wouldn't qualify for the surgery anymore, the doctor would kind of tell them, like, you need to back off of losing so much weight if you want the surgery. I remember thinking that that was kind of like an
really?
ethical.
You know, I had one patient who, she was so successful on the diet, she said, I don't know that I need the surgery. So she went longer on the diet, and I think she lost around 50 pounds, but then she went ahead and had the surgery. So, I don't know.
So I don't know if like certain hospitals have certain policies or something, but you'd be very adamant of like, oh, you're kind of approaching that percent that we discussed, so you can either stop losing weight before your surgery or continue to do the diet and then not do the surgery.
Interesting.
I don't know if that was his personal thing in the hospital, but.
So the goal of the psychological is determine if the candidate is able and willing to make the necessary lifestyle changes required for the weight loss. So you can look down there at the different categories that are assessed, like behavior, cognitive, emotional, and current lifestyle. So just kind of looking at those. So they're looking at behavioral. What have you done in the past? Have you ever tried to lose weight? Where have you been successful? Where have you not? Can you exercise? You know, what are your styles? Do you have maladaptive or weird dietary practices that we don't want you to continue on after you have the surgery? Do you have substance abuse? Are you currently using illicit drugs or recreational drugs, or is that a potential for you going forward? Health-related risk factors, impulsivity, working with them to recognize those and form other behaviors, or compulsive behavior patterns. Cognitive, emotional, understanding this procedure, what's it going to do to your body? You know, if you've been 400 pounds for a long time and you become 150 pounds, that's a huge body image shift. And I saw that I had one lady who was 440 pounds, and she underwent the surgery, and she went down to 150. She could not, she said, I just don't know who this person is. She eventually gained back 100 pounds and stayed at 250 and decided she was happy there. At 440, I'd never seen her walk, ever. And I saw her about 8 to 10 months after the surgery. She came back to me and she walked into the waiting room. It was really, and she told me that when her grandchildren had never seen her walk. So that was a huge thing for her. But she couldn't live down with the weight loss. Interesting. The risk of the procedures, people die. They're high-risk candidates. They've moved more now to doing under laparoscopic instead of opening them up, and that has reduced the mortality rate. Also looking at them understanding that behavior changes are key to effective weight loss. Also looking is, do they have the intellectual ability to deal with what the instructions, to comply, because it's more than just the diet, the medicines they have to take, the fluid amounts that they have to take in, coping skills, and then other psychological underlying problems. Looking at the life situation, are they in a stressful situation? Have they just gone through a divorce, had a baby, had a spouse die, had a parents die, some huge stressor, lost a job? What is their social support? Why are they doing this? What motivates them to do that? Are they realistic in their expectations of the surgery? Being assessed by a nutritionist or a dietitian, making a plan before, after, and what's going to happen to you while you're in the hospital. Assessing them medically for other comorbid diseases that maybe need to be fixed or treated or assessed prior to surgery. And then screening them for things that make them at higher risk for surgery, like apnea or cardiac risk. They're at higher risk for peptic ulcer disease, so addressing that prior to weight loss is important. Liver, renal disease as well. For women who are of childbearing age, they need to discuss birth control options. They recommend they not conceive for at least a year and a half to 2 years after surgery. Most of these patients will go on some type of thromboprophylactic agent, so Coumadin or heparin, for a period of time, and then what's their risk for anesthesia. So Jordan, anything you want to add to that? Did your dad go through a long pre-op workup?
I'm trying to remember, it was about 3 years ago, but I know that he had to lose like 40 pounds before they would even do the surgery, and yeah, he had to go through a lot of evaluations. And he still goes and sees that doctor quite a bit now.
The surgeon or the?
The surgeon. And so, part of the reason he did it too was because his hips were really bad from leaving the military and stuff, and so they were like, you need to lose this weight first, and see how your hips are doing, and then if they're still not doing a lot better, we'll do the bariatric surgery. So, it was probably 4 or 5 months of stuff before he even had the surgery.
Yep, that sounds about right. I think the minimum is 3 months. Okay, so the mechanisms of weight loss can be twofold. They can be one or the other or both, so they can be malabsorption. So the more invasive, like the Roux-en-Y is probably the most invasive, most change, causes a malabsorption syndrome. Or it can be restrictive. You can just restrict how much can go into the stomach, like the banding procedures are related, do that. And then some of them do both. So we're usually cutting out or taking out part of the absorption capacity of the small intestines. Or we're cutting down the stomach for the amount that you can put in there. Okay, let's take a break. We'll come back at 11 and pick it up with procedure types.